37% of patients over 65 taking statins will suffer a major cardiovascular event within the next decade anyway. The pill in your medicine cabinet right now, the one your doctor prescribed to protect your heart, may be creating more problems than it solves. And the pharmaceutical companies have known this for years. Margaret was 68 when she came to my office. She'd been on atorvastatin for 6 years. Her cholesterol numbers looked perfect on paper. LDL down to 70. Her primary care doctor was pleased, but Margaret could barely walk up her driveway without muscle pain shooting through her thighs. She told me she'd mentioned it 3 times. Each time, her doctor adjusted the dose or switched brands. The pain never stopped. She thought aging just hurt. Here's what nobody tells you. For seniors, the drug meant to save your heart can steal your strength, cloud your memory, and leave you more vulnerable than before you started. I'm Dr. Rahman, and I've performed over 2,400 open heart surgeries in the last 28 years. I've held beating hearts in my hands, hearts that were supposed to be protected by these medications. I've stood across from families in waiting rooms, explaining why their loved one is on my operating table despite doing everything right with their cholesterol management. The gap between what works in a clinical trial of 50-year-olds and what actually protects a 70-year-old body is a canyon. And most doctors are still following guidelines written for the wrong age group. Stay with me, because by the end of this, you'll understand exactly why your statin might be working against you, which 5 critical factors determine whether you should even be taking it, and what actually protects senior hearts. Information that should have been given to you years ago. The cardiovascular system, after 60, operates on entirely different rules. Think of your blood vessels like garden hoses. A new hose is flexible, resilient, responds to pressure changes. But a hose that's been in the sun for 60 summers? It's stiffer, less elastic. The walls have changed composition. You can't treat both hoses the same way. When you're 45, your arteries can handle aggressive cholesterol reduction. Your muscles recover quickly from statin side effects. Your liver processes the medication efficiently. Your brain maintains its cholesterol synthesis for cognitive function. But after 60, everything shifts. Your body needs cholesterol. It's not the enemy the commercials make it out to be. Every cell membrane in your body is built from it. Your brain is 25% cholesterol by dry weight. It's the raw material for vitamin D, for stress hormones, for sex hormones. And here's the critical part. As you age, your body's ability to produce and regulate cholesterol changes. The same medication dose that works for a 50-year-old can devastate a 75-year-old's muscle tissue, cognitive function, and energy production. A 2019 study in JAMA Cardiology followed 47,000 patients over 70. Those on high-intensity statins had 34% higher rates of severe muscle breakdown compared to moderate-intensity therapy. But most seniors are still being prescribed high-intensity doses because the guidelines don't distinguish. So let me walk you through the 5 factors that determine whether that cholesterol pill is protecting you or failing you. Each one matters. Miss even one, and you're gambling with your heart. First factor, your actual cardiovascular risk score, not just your LDL number. Your doctor runs a blood test, sees your LDL is 140, writes a prescription. But LDL alone tells you almost nothing about your real risk after 60. I've operated on patients with LDL of 90 who had completely blocked arteries. I've seen 80-year-olds with LDL of 160 and clean coronaries. The number by itself is meaningless without context. What actually predicts your risk? Your coronary calcium score. Your CRP level, that's inflammation. Your lipoprotein, A, genetic, can't be changed by statins. Your blood pressure pattern over 24 hours, not just the reading in the office. Whether you have diabetes, whether you smoke, your family history. These factors together create your true risk profile. But here's what's happening in most offices. Doctor sees the LDL number, compares it to a chart, prescribes the statin. No calcium scan, no inflammation marker, no comprehensive risk calculation. Robert was 72, LDL of 155. His doctor had him on rosuvastatin 40 mg maximum dose. Robert's actual 10-year cardiovascular risk, when properly calculated with all factors, 8%. Low enough that the side effects of high-dose statins outweighed any potential benefit. We stopped the medication, started him on targeted supplements and lifestyle modifications. 18 months later, his muscle pain resolved, his energy returned, and his actual cardiac markers improved. His LDL went up to 170. His doctor panicked, but his inflammation dropped, his calcium score stayed stable, and his functional capacity increased by 40%. Write that down. LDL is one data point in a constellation of factors. If your doctor is treating a number instead of treating your actual cardiovascular system, you're not getting precision medicine. You're getting protocol medicine. And for seniors, that gap can be dangerous. Ask yourself right now, do you know your coronary calcium score? Do you know your CRP level? If not, comment below. I need the full picture, and I'll know this information is reaching the people who need it most. Second factor, the type and intensity of statin you're taking. Not all statins work the same way in aging bodies. Atorvastatin and rosuvastatin are high intensity. They're powerful, they drop LDL aggressively, and they come with the highest side effect rates in seniors. Pravastatin and fluvastatin are moderate intensity, gentler, still effective for many patients, far fewer muscle and cognitive complaints. But here's what I see constantly. A patient gets started on high intensity because their LDL is too high, and they stay on high intensity for decades. Nobody ever asks whether a lower intensity would work just as well with fewer side effects. Your muscle cells produce energy in small factories called mitochondria. Statins interfere with a pathway called the mevalonate pathway. Same pathway that makes cholesterol also makes coenzyme Q10. CoQ10 is essential for mitochondrial function. Block it, and your muscles can't produce energy efficiently. For a 45-year-old with abundant mitochondrial reserve, this might cause mild fatigue. For a 70-year-old whose mitochondrial function is already declining, it can mean severe muscle pain, weakness, inability to exercise, increased fall risk. One study showed that seniors on high-intensity statins had 6 times higher risk of mobility disability compared to those on moderate-intensity therapy. And nobody tells you this before you start the medication. But here's where it gets worse. Once you develop statin-related muscle problems, they don't always resolve immediately when you stop. Some patients have persistent symptoms for months. Some develop a condition called statin-induced necrotizing myopathy, rare but devastating. Your immune system starts attacking your own muscle tissue, and it can continue even after the drug is stopped. I need you to stay with me here because the third factor is the one most doctors completely miss. Third factor, whether you're taking the medication with or without CoQ10 supplementation. Remember how I said statins block the pathway that makes CoQ10? Your heart muscle is the most metabolically active tissue in your body. It never stops. It beats 100,000 times a day. It needs enormous amounts of CoQ10 to function. When you take a statin without replacing CoQ10, you're essentially energy-starving your heart muscle while trying to protect it. The irony should make you angry. Every single patient I put on a statin, and yes, sometimes they're necessary, gets CoQ10. Not the cheap ubiquinone form that seniors can't absorb well. The ubiquinol form, 100-200 milliliters daily, taken with fat for absorption. This single intervention prevents roughly 60–70% of statin-related muscle complaints. But in 8 years of reviewing medication lists from patients transferring to my practice, I've seen CoQ10 co-prescribed exactly 4 times. 4 out of thousands of patients on statins. Why? Because it's not in the guidelines. Because it's a supplement, not a drug. Because doctors aren't trained in mitochondrial medicine. Because the pharmaceutical companies that make billions on statins don't make money on CoQ10. So patients suffer preventable side effects, stop their medications because they can't tolerate them, and then get labeled as non-compliant. Dorothy was 71. She'd stopped her simvastatin twice because of leg cramps. Her doctor tried a different statin. Same result. Netcom, lisenduent, letan. When she came to me, I started her on low-dose pravastatin with 200 milliliters ubiquinol CoQ10 daily. No muscle pain. 3 years later, still tolerating it well. Her LDL is controlled. Her quality of life is preserved. This should be standard of care. It's not. If you're on a statin right now and you're not taking CoQ10, comment "I didn't know" below. Let's see how many of you were never told. Fourth factor, your kidney and liver function. Statins are processed by your liver and excreted by your kidneys. After 60, both organs decline in function. It's physiology, not pathology. Your kidney filtration rate drops about 1% per year after age 40. Your liver's ability to metabolize drugs slows. The same statin dose that's safe at 50 can accumulate to toxic levels at 75 if kidney or liver function isn't monitored. And most patients never get checked. The medication builds up. Muscle breakdown accelerates. Breakdown products flood into the bloodstream. Your already compromised kidneys try to filter them out. In severe cases, this causes rhabdomyolysis, catastrophic muscle breakdown that can cause kidney failure. I've seen it happen. Not often, but even once is too often when it's preventable with a simple blood test every 6 months. Here's what should happen. Before starting a statin, baseline kidney function and liver enzymes checked. Repeat testing at 3 months, then every 6 to 12 months. Dose adjusted based on kidney filtration rate. If creatinine rises or liver enzymes elevate, medication stopped or reduced immediately. Here's what actually happens. Statin prescribed. Maybe one follow-up test in the first year. Then nothing unless the patient complains. And by the time muscle pain or weakness is severe enough to complain about, damage has already occurred. Thomas was 76, with early chronic kidney disease. His filtration rate was 48, mildly reduced. His cardiologist had him on atorvastatin 80 mg maximum dose for a patient whose kidneys can't clear the drug efficiently. When I saw him, his CK levels, that's the blood marker for muscle breakdown, were 11 times normal. He thought the weakness was just getting old. We stopped the statin immediately, started him on hydration and monitoring. It took 4 months for his muscle enzymes to normalize. 4 months of wondering if he'd caused permanent damage, all because nobody checked his kidney function and adjusted the dose. Starting tonight, if you're on a statin and you don't remember the last time your kidney and liver function were tested, you call your doctor's office tomorrow. Not next month, tomorrow. Ask for a comprehensive metabolic panel and kidney function test. Write that down. Fifth factor, whether there are alternative strategies that could work as well or better for your specific situation. This is the conversation that almost never happens. Doctor sees high cholesterol, writes statin prescription, appointment over. But for many seniors, especially those at low to moderate actual cardiovascular risk, there are evidence-based alternatives that don't come with the side effect burden. High-intensity exercise, if you're capable, can reduce cardiovascular events by 30 to 40%. That's comparable to moderate-intensity statin therapy. Omega-3 fatty acids at prescription doses, not the weak over-the-counter stuff, reduce triglycerides and inflammation. Plant sterols can lower LDL by 10–15%. Red yeast rice contains natural statins in lower doses that some patients tolerate better. Bergamot extract affects cholesterol metabolism through different pathways. PCSK9 inhibitors, newer injectable medications, work differently than statins and don't cause muscle problems. And sometimes, for the very elderly with limited life expectancy and low functional reserve, the right answer is no cholesterol medication at all. If you're 85, frail, with multiple medical problems, and your only issue is an LDL of 150 with no other risk factors, aggressively lowering your cholesterol might do more harm than good. There's actually data showing that in the very elderly, higher cholesterol is associated with better survival. But these conversations require time, nuance, individualized risk assessment, and most office visits are 15 minutes. I sat with a 79-year-old woman last month. She'd been on maximum dose rosuvastatin for 8 years. Muscle pain, fatigue, couldn't walk her dog anymore. Her actual 10-year cardiovascular risk was 12%. We stopped the statin, started her on omega-3, bergamot, CoQ10, and a structured walking program. 6 months later, her energy returned, pain resolved, she's walking 2 miles a day. Her LDL went up 40 points. Her cardiologist was furious, but her inflammation markers dropped, her functional capacity doubled, and her quality of life transformed. It is never too late to ask whether what you're taking is actually helping you. I need to tell you something I don't talk about often. I've stood in operating rooms at 2 a.m., hands inside a chest cavity, looking at a heart that's been destroyed by a lifetime of silent inflammation and arterial disease. And in the waiting room outside, there's a family who did everything their doctors told them to do. Took every pill, followed every guideline, never asked questions because they trusted the system. The number of times I've reviewed a medical history and seen years of high-dose statin therapy with no monitoring, no side effect assessment, no adjustment for age or kidney function, it stays with me. That question has stayed with me. These aren't bad doctors. They're overworked doctors following guidelines that weren't written for 70-year-old bodies. They're operating in a system that rewards prescription writing and penalizes time spent on nuanced conversation. But the result is the same. Seniors suffering preventable side effects, losing functional capacity, sometimes losing independence, because nobody stopped to ask whether the medication still made sense. Margaret, the woman I told you about at the beginning, we stopped her atorvastatin. We ran a calcium scan. Her calcium score was low. Her actual risk didn't justify high-intensity therapy. We started moderate-intensity pravastatin with CoQ10, added omega-3 and plant sterols. 3 months later, she called my office. She'd just walked 18 holes of golf for the first time in 3 years. Her muscle pain was gone. Her energy was back. She said to me, "Why didn't anyone tell me I had options? I thought I just had to live with the pain." That question has stayed with me. Let me give you the 5 factors again, because these determine everything. 1. Your actual cardiovascular risk score, not just your LDL number, demand the full picture. 2. The type and intensity of statin matters for aging bodies. High intensity isn't always better. 3. CoQ10 supplementation should be automatic with any statin prescription for seniors. It prevents most muscle side effects. 4. Regular kidney and liver monitoring is non-negotiable. Medication doses must be adjusted as organs age. 5. Alternative strategies exist. Exercise, omega-3, plant sterols. Sometimes no medication at all can be the right answer. If you're on a statin right now and you've experienced muscle pain, fatigue, or weakness, comment below with your age and how long you've been taking it. I want to know how many people this is affecting. And if this information helped you understand what's been happening to your body, share this with someone over 60 who's taking cholesterol medication. They need to hear this too. Subscribe to this channel if you want more information about senior heart health that actually accounts for your age, your specific situation, and your quality of life, not just guidelines written for younger populations. This video isn't medical advice, and I'm not your doctor. I'm a surgeon who spent 3 decades watching the gap between what's prescribed and what actually helps seniors. Every person's situation is different. Your medications, your risks, your decisions should be made with a physician who knows your complete history and takes time to explain your options. What I want is for you to walk into that office informed, asking the right questions, and demanding the conversation you deserve. Your heart has been working for you every single minute of every day since before you were born. It deserves protection that actually works for the age you are now.